Um, did everyone get a record message?
Yep.
Okay.
All right. So we are section C, group 9A, and this is what we came up, our proposal for case C.
Okay, so to start off, we're going to be discussing radical belonging and the definition that we have for radical belonging. My name is Isla. I'm part of the pharmacy program. So what we did is we first came up with different brainstorming ideas of what everybody thought radical belonging is, and then we developed our definition. So radical belonging is something, is referring to something where everybody from different backgrounds are respected and appreciated in a specific environment, whether it's a workplace or a school place. So it doesn't matter if it's a religious background, a cultural background, even a professional background. Everybody needs to be respected and feel like they're heard. And they also need to feel like their input is valuable to a certain discussion. So we came up with the definition: radical belonging refers to both individual feeling of acceptance through social, academic, and democratic lenses, and collective effort to acknowledge people from different backgrounds in social and academic settings, as well as to learn or fix any injustices for an inclusive and stimulating environment. So moving forward as to why is radical belonging important in healthcare? So as mentioned previously, everybody needs to feel like their insights are valuable to a certain place. So in the workplace, people with different backgrounds might have different things to add, whether it's in treatment of a patient or discussing a certain case. Anything that they can contribute to should be respected, and they should feel like they're able to share. So belonging in healthcare teams is important as it correlates to success in terms of patient outcomes, as well as interprofessional collaboration. Inclusiveness is important in a team environment, and appreciating all backgrounds and the input from those people paves the way to successful multifactorial care.
All right, so this is about our proposal that we actually have for the Hope Commission. I'm Amelia. I'm one of the medical students. So the first thing that we did is that we have our proposal divided up into organizational, team, and individual. So on the organizational front, the first thing that we propose is that they have appropriate staffing members in all areas. So we know that there's a little bit of a shortage in staffing, but we think that's really important to make sure that the staffing is up to the numbers it needs to run the department properly. The other thing that we recommend is flexible scheduling. And the ability to be able to trade shifts and time off, because emergencies happen and there needs to be a more flexible way so people don't feel like that they absolutely have to be there all the time and there's no way for them to get out of their shifts. We would also like for there to be dedicated areas for breaks and relaxation. So like having like an area that has like couches and snacks and then invites people to come in and be able to interact with others. The other thing that we propose on the organizational level is that we give incentives for house staff to become medical translators. So this would be like paying for the time off for them to get the continuing education or giving them a stipend for the exam. And then the last thing we would like on the organizational level is to allow for dedicated time and designated spaces for those who have religious practices. On the team level, what we propose is that we would like for there to be onboarding and continuing education on compassion fatigue, and this all to be done as a team. So then you get everybody on board with this. The next thing we'd like is for to have organized events for socialization so people can get to know each other, that you can build a better team and that people feel like they've actually know each other and that they have like a community there. The other thing is we'd like frequent interprofessional team meetings, so that people get to put their input in all the time. And then on the individual level, we would encourage people not to have email on their personal phones that is related to work. So then they're able to check out and not be as stressed about work. The other thing is we would recommend leaving the workspace to have lunch. This could include like leaving the building or having a dedicated area that's outside of the actual work environment. So then people can check out for lunch and come back to it later.
My name is Carly. I'm from nursing, and I'm going to talk about the impact of COVID-19 on marginalized communities. Obviously now 2-3 years into this, we have a lot of data, and it's pretty clear that there's health disparities, and so there's a disproportionate impact on racial minorities. Just some statistics here, according to COVID data collected by the CDC, is that all non-white groups have 1.5 times greater risk of infection with COVID-19, and Black Americans are twice as likely to die from COVID-19. That second statistic is obvious in St. Louis too. On our own COVID dashboard, you can see that COVID-19 mortality is 1.86 times higher in African Americans in St. Louis than in white St. Louisans. So another issue that has come up related to COVID is an increase in hate crimes directed towards Asian Americans. So in some data collected by UCLA, more than 1 in 12 or 8% of Asian Americans, Native Hawaiians, and Pacific Islanders have experienced hate incidents due to COVID-19. And 84% of those were verbal assaults. So obviously, these are extremely complex issues. The impact of COVID-19 is not simply like physical, epidemiological. So I thought in order to simplify it, we could examine this through the lens of policies that already exist. So marginalized team members are already protected under federal employment laws and existing facility policies. So a crucial step before spending resources on initiating new interventions is really like evaluating and assessing the policies that we do have and if they are effective in addressing disparities and if they're enforced. So the first thing is to evaluate and update the grief and bereavement policies. So in our case, there was Chandra was a physician, and she had lost 2 family members this year. So during this really hard time, a really easy way that we could support people in marginalized communities that are experiencing a greater impact of COVID-19 is to extend the bereavement policy so they're not running out of days off when a considerably greater amount of people in their communities are passing. And then second, and the most important one, is to strengthen compliance and enforcement of anti-violence and anti-discrimination policies. So that would include solidifying avenues for employees to report abuse and receive support, invoking and reinforcing strict consequences for discriminatory comments and behaviors, assessing the efficacy of trainings related to discrimination, and implementing an updated curriculum that would educate on microaggressions. It would facilitate a biased self-assessment, and it would teach ways that staff can advocate for themselves and for others when dealing with discriminatory patient behavior. So this is the most important because several employees in our case mentioned that they felt insulted or discriminated against by staff and patients in their workplace. And that is really not acceptable if our goal is radical belonging. We won't get there unless all staff feel protected and heard at work. And really, these changes are just good for everyone. This work is hard and uncomfortable, but the costs don't outweigh the benefit of maintaining a space that is safe and supportive for all.
Hi, my name is Lynn. I'm a medical student, and I will be elaborating further on what Carly was mentioning about how we can support marginalized communities, especially within the hospital. So something that we looked into was encouraging individuals to find a community within the hospital. And many of the people in our case were bilingual and enjoyed talking with patients in their native language. And that's something that as a hospital, as an organization, we can help encourage, especially through incentives by providing jobs and allowing for mobility for those employees that are interested in pursuing that. So what we looked into was certification for medical interpreters. So we say that it would empower marginalized communities by allowing for opportunities to form connections with patients and staff within the hospital through interpretation training. So looking specifically into this, we found that the National Board of Certification for Medical Interpreters would be the avenue for individuals to pursue, just so we ensure that individuals that act as interpreters have a board certification for it. So there are 6 languages that are available for a CMI, specifically a certified medical interpreter. That would be Spanish, Cantonese, Mandarin, Russian, Korean, and Vietnamese. And we looked into the total cost it would be for an individual if they were to go through that, not counting time they would spend on their own in order to pursue these certifications. And we found that it was about $785. If a language is not within these 6 languages for a CMI, a hub CMI is also available. And that is just a more of like a distinguishment. Extra training goes into a CMI, but a hub CMI is still a certification. And that would be any language that is not among those 6 languages. And that would be $510. So we feel that organizations can help incentivize staff and support them to pursue medical interpretation by funding these costs for certification, and then also paying accordingly if they decide to add that extra title to their job. We also looked into whether or not this would be cost effective in the long run for hospital systems, especially because they're commonly right now, what's being used, at least from what I've seen, is like a telehealth medical interpretation. So is it cost effective to use people for this? And there is actually some research that I've looked into that, and they have found that use of professional interpreters has lasting benefit, long-term goals, and long-term benefit for both patients' medical care, and then it can also help decrease overall long-term costs for healthcare systems.
I'm Emily. I'm from physical therapy. Next, we're going to be talking a little bit more about how to implement the changes that we suggested in our proposal to the Hope Commission. So there are a few key steps that we decided on that will help the Hope Commission implement these changes and recommendations at the individual, team, and organizational level. The first is to schedule regular meetings about any changes being made to make sure that everyone's on the same page, and to encourage buy-in from all affected members of the organization. Because if the employees don't buy into the recommendations that are being proposed, no real changes will ever be made. This also provides a set time to address any questions or concerns regarding any new changes. And again, just to make sure that everyone is on the same page before moving forward. After establishing some of the key implementation steps, we broke our ideas down into a short and long-term roadmap for implementation. So starting with the short-term implementation steps, these focused around fairly simple changes that can be made regarding improved communication strategies and encouraging interprofessional collaboration. The first idea we had for short-term implementation is to initiate interprofessional sign-out or giving report at the end of each shift. This provides a set time for each patient's healthcare team to communicate with each other and relay any important information to make sure that nothing is being missed that could jeopardize the patient's care. Similarly, we also suggested interprofessional huddles or meetings to take place on a weekly or bi-weekly basis, which is similar to giving report, but gives everyone more time to address any questions or concerns that have come up and consult with any other healthcare professionals to determine the best way to proceed. Continuing with the theme of improving communication, we also want to advertise interpreter services to minimize any mistakes or miscommunication due to a language barrier. And lastly, implementing interprofessional social events once a month would help bring all the employees together and give them a chance to bond outside of the work setting to boost morale and decrease burnout. As for the long-term implementation steps, we want to provide outdoor and indoor areas for lunch away from the workplace, which can be really beneficial for employees because it gives them a chance to get away from the stress of work, clear their head, take some time for themselves, and come back refreshed and ready to finish the rest of their day. Something that's having a huge impact on healthcare workers since the start of COVID is staffing shortages, which results in employees being overworked, having their requests for time off denied, and organizations experiencing widespread burnout from their employees. So in order to address this, we recommend implementing a method for more flexible scheduling that gives employees more of a say in creating their schedule and making sure they're getting their paid time off that is essential to minimizing burnout and encouraging productivity. Lastly, having a council that is made up of at least one representative of each profession or department in which they can speak for their team and bring any questions, concerns, or recommendations forward as to what's going well, what can be improved, and anything that they might need in order to be successful.
Okay, so hi, I'm Maya. Sorry, I'm a little sick. So can you guys hear me okay? Okay, so the metrics of success that we talked about were surveys sent out every quarter to all the professionals and seeing their satisfaction about the changes in our radical belongings, excuse me, and then monitoring employee retentions.
Cool. Yeah.
There we go, thank you. And how is this sustainable and how can it be used in other settings? So most of the input about the changes and how changes came about come from the current employees. So we can kind of continue to have the surveys and meetings about the implementation and like taking in ideas for improvement. And then it can be used in other settings because it's used amongst all interprofessional teams. So it can kind of be used in various settings in that way.
All right, my name is Hope. I am a physical therapy student. So I'm going to talk about the effective teamwork among the disciplines that we showed during this project. So first thing that's the most obvious is we all have different chosen professions, meaning that we all know different areas of the hospital in the case. So one of us might understand what, for example, I understand what PT does very well. And I had to sometimes explain it to other people at different times. People know I don't know as much about pharmacology, so Isla talked to me about that, things like that, about how we would be involved in each of these different categories. The next thing is that people related to different people in the cases in different ways. So the case showed us multiple different people that worked in the hospital, and each of these people had different professions, different religions, and different languages, different worldviews in total. So there was different options of who connected with who. For example, a doctor might be more have more connection with a medical student, or somebody that is Christian might have more connection with a Christian. People that speak different languages and understand what it's like to be in a hospital and speak that language with patients might understand that person's perspective just a little bit differently and be able to communicate that with our group. So with all these different things coming into play and all these different worldviews, we decided how we were going to be most effective is that we were going to have one person lead the questions. So one person would just guide our discussion and say, hey, that we're on this question. What do you think about this? And then we gave each other opportunities to speak. If we had ideas about specific topics, about specific people in the case, specific ideas, one of us would speak up. We also did a very good job of involving other people by asking questions of specific professions, of where they would be involved, how their specialty would modify it, what they think is best for that patient based off what their priorities are as a profession. And that led to us bouncing ideas off each other the entire time that we were working through this. We had a lot of ideas that we kind of narrowed down to a fair amount, but still, like us, we felt very solid in order to make sure that we addressed all the categories, including organizational, team, and individual. And then obviously we worked until we liked it. So we kept going until we figured out exactly what information we needed, what ideas we liked, which ideas we didn't like, and then we came up with a presentation to present to y'all. Obviously, at this time, technology both helped and hurt us. We were able to communicate and do things all through Zoom, which was very beneficial because all of us are in different professions with different schedules. We're never in the same building at the same time, so it was really helpful to have technology. But at the same time, it hurt us a little bit just because, you know, not being able to see each other, not being able to physically have a meeting spot can be a little difficult sometimes. And sometimes it's difficult to hear. Sometimes if two people are talking at once, one of them gets cut out with technology. Things like that can be a little bit more harmful. But overall, we feel like we made it work very well. And this is kind of what we all thought we did well in this whole situation of IPTS and presenting case number 3. Thank you for listening to this presentation.